Morning, everybody, and welcome to the first webinar talk series of the year, first semester 2024. I hope everybody had a fantastic leave if you took, and everybody's come back rested and rejuvenated for the beginning of 2024. Please let us know now if there's any audio or visual issues that you pick up so that we can work on that. This morning, we've got two talks said. We've got a talk regarding the pathophysiology of chronic renal failure by Dr. Rhode, and then we've got a talk following that regarding transplant surgery by Dr. Sikasa. So without further delay, we're going to ask Dr. Rhode to start us off. Thank you, Lara.
Right. I hope that's projecting. All right. Okay. Morning, everyone. I'm Elisha. I'm going to be presenting on the pathophysiology of chronic renal failure. Just chat quickly, start off by looking at what is chronic renal failure, how do we grade it, have a look at what's our normal anatomy and physiology of the renal system, how does renal injury progress from sort of minor to more severe, what's the mechanisms by which it goes through that progression, what are the disease entities that lead to it, and finally we'll just wrap up by looking at the clinical manifestations as a consequence of the pathophysiological mechanism. Right, so I mean, to start with the problem, you need to understand what exactly is the burden of the problem. And from the evidence that we've got in the last 3 decades, there's about a 30% increase in the prevalence of chronic kidney disease. They say that there's 2 times more people in the world with chronic kidney disease as opposed to diabetes, and there's 20 times more people in the world with chronic kidney disease as opposed to HIV. It would be interesting to see those statistics in the context of Africa, but like most things, you know, the data is scanty on our side. But what we do know is that, firstly, there seems to be a prevalence in South Africa of about 10.7 compared to the general population. But more important, and what speaks to the public health aspect of chronic kidney disease, is the fact that there's a significant socioeconomic disparity in South Africa, with poor or low socioeconomic circumstances being an independent risk factor for chronic kidney disease. Right. So chronic kidney disease, as defined by the KDIGO group, has 2 components. Firstly, it's kidney damage, and that kidney damage has to be demonstrable for a period of 3 months or more. What constitutes kidney damage can either be demonstrating a decrease in the glomerular filtration rate, the presence of albuminuria or proteinuria, the presence of urinary sediments, such as white cell casts, red cell casts, imaging that for that disease entity maybe demonstrates appropriately a small kidney, biopsy-proven pathology in keeping with a chronic disease process, or a patient that is obviously getting a kidney transplant or is on the kidney transplant list. By definition, that person has kidney damage. They further go on to grade CKD, the KDIGO group, and they've got 2 components. One is glomerular filtration, and that goes without saying, but the other one is albuminuria or proteinuria. And the reason that they use albuminuria is that albuminuria is a sensitive marker of endothelial dysfunction in not only the kidney, but throughout the body. And if one plots those 2 on a graph, you can get a heat map. And that heat map demonstrated here as green, orange, red, predicts individuals that are at high risk of all-cause mortality, that are at high risk of progression to end-stage renal disease, and that are also at high risk of having a consequent acute kidney insult that could push them into a higher risk group. But away from the clinical and back to the fundamentals, this is the structure of the kidney, and we know that macroscopically our kidney has a renal parenchyma made up of a cortex and a medulla, and that medulla is going to produce urine. It's going to go down through the pelvic calyceal system into the ureter. Significant to the function of the kidney is that it's got a dense vascular network surrounding it that comes off of the segmental vessels, goes interlobular, arcuate, interlobular, interlobar, arcuate, interlobular, and then forms this glomerular, which we'll come to in a bit, as well as this peritubular network that plays a significant role in the physiology and functioning of the kidney. So focusing on the kidney, we know that the kidneys main functional unit is the nephron, which consists of two parts. It consists of the renal corpuscle, also known as the Malpighian body, named after the Italian who first identified it, Marcello Malpighian. And that consists of a tuft of capillaries known as the glomerulus, and that's surrounded by what's termed Bowman's capsule. The rest of it is then the tubular system, made up of the proximal convoluted tubules, the loop of Henle distal, and the collecting ducts. Now, if we zoom in a bit on the Bowman's capsule and the renal corpuscle, it's got an interesting morphological makeup that is pertinent to the function of the kidney. And that is that if we look at it in three layers and we say that the endothelium is demonstrated on this side, we know that this endothelium is fenestrated. But more important to that endothelium is that you've got negatively charged macromolecules, specifically your glycosaminoglycans and your glycosaminoglycans, which are also inhibitors of stone formation, but they form a negative charge which prevents macromolecules from passing through that fenestrated endothelium. It then has a basement membrane, which if you look back here at the overall structure, that basement membrane is continuous with the surrounding parenchyma around that, which is also termed the mesangium. And outside of that, we've got these foot-like processes known as podocytes, all significant to its function. Now, that mesangial area is made up of two types of cells, intrinsic glomerular cells and tissue macrophages. They play a role in the immune system of the kidney, and they're specifically in the glomerular nephrites. They also play a role as to why that sort of occurs there, as opposed to disorders of vascular function. I like this image because we often see this as a two-dimensional structure, when in fact it is a three-dimensional structure. And Starling's forces describes how we're able to filter fluid through our kidney. We know that according to Starling's law, we need, or the factor that determines how much we're filtering through is one, the surface area, which explains why we've got a tuft of capillaries. It increases that surface area. Number two is the permeability, which we know is why we've got fenestrated endothelium, all right, as well as negatively charged to keep out the macromolecules we don't want to lose. And then it is a combination or the difference in the hydrostatic force or the blood pressure driving blood into the glomerulus, as well as the oncotic pressure pulling blood on the Bowman's capsule side and vice versa as in terms of opposing. The descending limb, we know it's a thin descending limb. It's permeable to water. We'll come to that in a bit. It plays a role in the countercurrent multiplier, as well as the ascending limb, which is permeable to solutes via active transport. Right, now, the kidney's got a number of functions, and perhaps there are those that can remember this off the bat, but my mind sometimes is very Neanderthal-like, and I need mnemonics to tie up the function to it. And this, for me, makes the most sense. I like remembering the functions of the kidney according to a wet bed. Now, if you run through this, you can quickly just discuss what are the kidney functions. And firstly, we know that it functions along with the lungs in maintaining the acid-base balance of the body. Quick system is the lungs. We can quickly correct the acidosis with breathing. The delayed system is the kidneys, which can either excrete hydrogen ions or regenerate and reabsorb bicarbonate as a form of buffering. So that's how it deals with acid-base balance problems. Water balance is tightly tied to sodium. And as mentioned, we filter water through, and then using our countercurrent multiplier, which maintains a hypertonic interstitium around our loop of Henle, we're able to reabsorb water and keep that back. And that's important for both water and sodium. Other electrolytes that we know about, we know that the aldosterone-mediated transport of potassium takes place in the collecting ducts. And that's important for us in getting rid of potassium. And also calcium. We know that calcium is one of the areas that is targeted by parathyroid hormone. And it is an integral role in reabsorbing calcium in terms of the homeostasis of calcium. Toxin removal, endogenous. We know that the breakdown of amino acids and muscle leads to nitrogenous waste products, and we need to get rid of that. Secondly, medications. Medications in their form of toxins, and the kidneys aid in getting rid of that. Blood pressure. So just tying in with the water balance, just to remind everyone, it's a vague concept, but we remember that our kidney has an autoregulation system, two main components, but a myogenic and a tubuloglomerular feedback mechanism. And that tubuloglomerular feedback mechanism is made up of the juxtaglomerular apparatus. And simply put, if you can remember it in your mind, it is basically that distal convoluted tubule that is bent over and right adjacent to the glomerulus through which the blood was coming in. And using that mechanism, essentially, it can sense the salt at the end of that entire cycle via the macula densa, and that will stimulate the granular cells to release renin, which will kick off the ROS system. And so doing, you're going to get efferent constriction, and you're going to hyperfilter during times of decreased sodium, which acts as a surrogate for decreased glomerular filtration. Erythropoiesis, taking you back, we know that the second level hydroxylation using 1 alpha or 24 alpha once it comes from the liver as 25 alpha hydroxylase or 25 hydroxycholecalciferol. It will finally be converted into calcitriol in the kidney, and that's an important mechanism of calcium hemostasis. Not calcium. it's an important, yes, of calcium reabsorption from the gut. And then erythropoietin, which is released from the peritubular cells, which stimulates the bone marrow to produce red blood cells and also to mature red blood cells. So, that's in short sort of how the kidneys function. I don't want to spend too much time on that because I think we'll touch on that when we come to the pathophysiology. Well, demonstrated here is just sort of how we progress, and that it's not that we suddenly go into renal impairment. It's a stepwise progression that correlates neatly with the degree of loss of glomerular filtration. And it ranges from the patient that's just at risk because they've got a decreased function to the patient that is overtly in failure with a significant electrolyte and metabolic disturbances. Now, from a pathophysiological point of view, the stages of progression, and there's an interesting article that I've referenced here at the bottom, can be looked at or is theorized to be based on compartments. And if it makes sense to you that you've got the vascular compartment made up of the glomerulus, you've got the tubular compartment, and you've got the interstitium. And wherever the insult is, whether it's a glomerulonephritis or a tubulopathy, wherever that is, it starts to stimulate the other one. So as an example, if you have a vascular issue that causes all of a sudden inflammation, that's going to stimulate the cytokine release elsewhere, which is going to denude the basement membrane in the glomerulus. And that's going to cause all sorts of damage to the podocytes, to the filtration mechanism, and it's also going to affect the tubules. So despite the fact that renal damage might occur in a single compartment, it's theorized that this obviously drives intercompartmental injury. Right. Next slide, I think the crux of this that I want to come to is you get an injury, there's some epigenetics involved, and I think the one of interest to sort of Africa is looking at apolipoprotein 1, which is thought to be an epigenetic mechanism driving renal impairment in African population. And then sort of that's a very interesting and novel thing that they're looking at. But what happens is you've got this insult, it's going to progress, and our renoprotective measures are meant to try and stop it from reaching the stage of glomerular sclerosis or interstitial fibrosis. So the etiologies causing CKD, I've taken this table straight out of the Campbell's, but wherever you look, the vast majority of data is showing that diabetes and hypertension overwhelmingly in the world is the most common cause of renal dysfunction. But in the next few slides, I just want to pull out one or two of these and just have a look. I want to look firstly at hypertension, secondly at diabetes, and thirdly, I also just want to have a look at HIV-associated nephropathy, seeing that it is an important thing to consider in the African population and South Africa. So quickly, the urological causes, which aren't as many, but something that we must bear in mind. We know that these can be congenital or acquired. Congenital, the most common cause is vesicoureteric reflux, not in and of itself, but because we know that infection drives renal scarring, and that will eventually result in chronic impairment. Abnormalities of kidney structure, obstructive uropathy, be that acquired or congenital. And then we know that patients with stones have a higher risk compared to the general population of developing CKD. We know that if you combine that with being a female or being overweight, that's an even greater risk. And it also reminds us that we've also got our congenital stones, such as those with cystinuria or primary hyperoxaluria, who are also prone and should be monitored for chronic kidney disease. Now, hypertensive nephropathy, which is probably listed as often the most common nephropathy causing CKD, has got three pillars on which it causes damage. Number one, you've got vascular disease, and that makes sense, just like elsewhere in the body. High pressures, the intima of the vessel gets thickened or hypertrophied, and you also start laying down these hyaline deposits, which is sort of proteinaceous structures like a atheroma, which starts clogging or occluding the vessel. The glomerular sclerosis is then driven by damage which is both immune mediated as well as from the narrowing itself, which starts to damage the basement membrane. And then you've also got the interstitial fibrosis and tubular atrophy that results. It's not quite well understood, but it's also thought to be cytokine mediated. Diabetic nephropathy is quite an interesting one. I think it's interesting because there's a lot of us that walk around with a sort of a historical knowledge of diabetic nephropathy. But when you read a little bit on what the nephrologists are saying, Perhaps they're just reinventing the wheel, but it's interesting take on what encompasses diabetic nephropathy. The first point is that diabetic nephropathy, as we understand it, was traditionally described as type 1 diabetic, who's got established retinopathy, who has albuminuria with that. All right. But what we know is that it's not only type 1 diabetics, and you don't have to have retinopathy to necessarily have diabetic associated kidney disease, which would probably be a better term. But from a histopathological point of view, classic diabetic nephropathy has got, to sort of explain it, you've got high amounts of glucose glycolate, so it binds to amino acids, all right? And then they form what we call advanced glycation products. And these basically create a nidus for atheroma or plaque formation, which drives some of these pathophysiological processes. It will cause the glomerular basement membrane to thicken. It denudes the protein, specifically, as we said, is there's negatively charged aminoglycoproteins on the fenestrated endothelium. It denudes that. That obviously drives the albuminuria. The mesangium expands, collagen is deposited over there, and that sort of starts to get this collapse or sclerosis around that. Now, diabetic nephropathy also goes by another name, which is Kimmel-Steele-Wilson syndrome. And this nodular appearance or nodular intercapillary glomerular sclerosis is known as Kimmel-Steele nodules. That is not only, that's not every type of diabetic associated kidney disease has to have that, but that is described. There's a nice description by the pathologists where they actually grade this according to the amount of glomerular basement thickening, the endothelial damage, and the presence of either nodular or global intercapillary glomerular sclerosis. Right, HIV-associated nephropathy. So HIV-associated nephropathy HIV-associated nephropathy is basically a patient with HIV. They've got a low CD4 count and they've got nephrotic range proteinuria. Mechanism behind it is we believe that the HIV virus goes and attaches to the endothelial cells, causes direct damage, causes the release of inflammatory mediators, and that results in this collapsing glomerulopathy that they describe. And you can sort of, so I've taken that around, but they've kind of tried to illustrate it here and also histopathologically illustrate it. Once again, apolipoprotein B. This is a gene that's been looked at in both hypertensives of African descent, in both people with HIV of African descent, because it's believed to be an epigenetic factor that contributes to chronic kidney disease. Right, so that's sort of the pathophysiological and histological mechanisms, but that leads to our clinical presentation for chronic kidney disease. And I think what makes it interesting is through that pathophysiology, you can quite clearly see why people develop certain symptoms. So the first one, if we follow this a wet bed mnemonic, we can start with the acid-base disturbance. And understandably, if you're not filtering, you're not getting rid of hydrogen ions, and it's also not generating bicarb. So you've got to find an alternate way, and one way that it does that is that it buffers through the bones, and we'll come to that renal osteodystrophy in a bit. The other way is you're obviously accumulating your waste products such as ammonium. What that does is that's toxic. It causes complement activation. It drives fibrosis. ROS, or the renin-angiotensin-aldosterone system, it's great in the short term, but if you read it in most pathophysiological processes, eventually it becomes a little too much, and that also drives interstitial fibrosis as well as endothelium. So renal osteodystrophy, I think, as much as this is really sort of, I don't think the general urologist deals with this every day, but what it does demonstrate is quite neatly how the pathophysiology leads to bone disease. And as much as this is quite a full thing, if you can just follow me with this, we understand that there's decreased vitamin D activation or calcitriol activation in the kidney, which means that essentially we absorb less from the gut, which means that we get hypocalcemia. On top of that, we can't dump our phosphate into the urine, so we're accumulating phosphate. Both are stimuli for the release of parathyroid, and what parathyroid will do is try and chow the bone to try and release more calcium. That causes remodeling and redistribution and osteitis fibrosis. At the same time, as mentioned, you're using the bone or phosphate system to buffer this acidosis because your kidney is not able to do that. It's going to cause bone dissolution, and that drives decalcification, osteoporosis. And then finally, you've got toxins circulating. In kids, that toxins drive a protein-calorie malnutrition, so they develop rickets. And the adult form of rickets would be osteomalacia, which is also driven by a decreased responsiveness to the vitamin D receptor. So disorders of water and electrolyte balance, I think this one we sort of commonly better understand. You don't filter through. You are unable to maintain that high osmolarity of the interstitium of the renal medulla because you're not getting sodium through, so you tend to retain fluid. This pushes patients into heart failure and pulmonary edema. On top of that, aldosterone is not working that great to get potassium excreted. So you're driving a process that's leading to hyperkalemia. And then specifically in diabetics, we often speak about renal tubular acidosis type 1 and type 2, but type 4 is hyporenemic hypoaldosteronism. And that also drives hyperkalemia essentially because you're not able to get aldosterone out. It's not sensitive to aldosterone, and essentially you're retaining potassium, which contributes to the hyperkalemia of chronic kidney disease. Toxins, as mentioned, we're keeping back nitrogenous waste products directly toxic to the heart, causes pericarditis. Encephalopathy is an interesting one, multifactorial. They believe that it disrupts the blood-brain barrier. They believe that we're keeping some of that negative stuff in the gut, which is why we use lactulose to try and just transit it out. And it's also believed that excitatory neurotransmitters such as GABA circulates around, which can drive things such as fasciculations, seizures, and all of that. The urea is also directly toxic to our complement system. It prevents chemotaxis. It suppresses the immune system. They get infection. And I think the one that for me was interesting in reading this, sorry for the typo, is the uremic frost. We always see it, but it was just interesting to read about it. And the exact mechanism of that is you've got this highly concentrated urea in your sweat, which rapidly evaporates. And that leaves behind this frosty, salty substance, which is the uremic frost. And the pruritus that they get is from the calcium that they're not getting rid of, and it starts to deposit under the skin. Okay, last two, anemia and erythropoiesis. So anemia is also multifactorial. I think the one we often speak about is, which makes sense, if you've got decreased erythropoietin release. But they've also got this uremic toxins that are suppressive on the bone marrow, which drives anemia as well. And the other thing is that if you're not filtering through your hepcidin, if you don't get rid of it, hepcidin starts to cause some issues. Number one, it stops you from absorbing it from your intestine, the iron, and it also stops the macrophages from recycling iron, so putting it back into the system. And both of those drive an iron deficient component of chronic kidney diseases, anemia. And then this one, which to me is probably more urologically relevant, is sexual dysfunction in the patient with chronic kidney disease. They say that about 56% of people on dialysis are impotent, and a large amount of them suffer from erectile dysfunction and sexual dysfunction. Once again, like most of these things, they're multifactorial. The first three headings here are directly from complications of CKD. Either CKD is causing some issues such as the anemia, the neuropathy, or the uremia, or it's disrupting the endocrine function, or, which makes sense, the underlying disease that has led to chronic kidney disease, such as in the vast majority of these people, vascular disease, advancing age, obesity, or medications that they're using, has started to damage structures that are important for sexual dysfunction. And then finally, it's not great to live with chronic kidney disease. So there's also that psychological component. So that's the pathophysiology of chronic kidney disease in a nutshell. I think for me, take-home points is probably that kidneys are functionally critical structure. I don't think you need me to have come here to tell you that today. But once you drop 50% of your function, you're on the path to a relentlessly progressive loss of renal function, and it starts to become a one-way train to a very bad place. But fundamental to understanding the pathophysiology is obviously understanding the physiology, because it's one of those places in the body where directly all those pathophysiological sequelae make sense in view of the normal physiology. All right, thank you very much.
Thank you, Dr. Rhode, for that excellent presentation on CKD. I think you've got all the concepts quite well down there. Your understanding of the topic is also quite exceptional. Just one question. If you've obviously touched on the sort of pathological outcomes or the systemic issues which can occur in patients with CKD. If you're seeing a patient with CKD in the clinic, is there any sort of advice you'd give them if they're not quite end-stage kidney failure yet? What sort of advice would you would you give them regarding their condition and management forward?
Okay, thanks for the question, Cleve. Yeah, I think I think what your question speaks to is renoprotective management, and the first thing is that what is the underlying etiology, such as correcting the hypertension, ensuring that the HbA1c is optimal in the diabetic. In the HIV-associated nephropathy, you want to get that CD4 up by starting them on highly active antiretroviral therapy. And then, some of the things that we do is, if we look at the mechanism of the proteinuria, if we think of those two pipes, the afferent and the efferent arterial, angiotensin is going to constrict that efferent to try and drive the afferent through the kidney, and that drives the proteinuria. If you can block that using an ACE inhibitor or angiotensin receptor blocker, you can open up that efferent arterial, and that will cause you to not hyperfilter as much. So that's the idea behind enalapril, and I know that the primary care recommendations, especially in South Africa, recommend starting an angiotensin inhibitor or ARB as tolerated for that sort of thing. Other than that, I mean, you're correcting in terms of our urological causes. I think for the kids, that's an extensive discussion in vesico-ureteric reflux, but it speaks to infections, and the importance of identifying infections early in those kids to prevent renal scar formation. So I think from a urologist point of view, it's that just being sensitized to what is the pertinent issue. We can talk about all the other things around VUR, but we don't want kids to go and end up with chronic kidney disease. So those are sort of the things that come to mind. But I do think at the end of the day, it's a tailored approach.
Yeah, thanks, Eli. Yeah, I mean, it's the things you mentioned that you most of the time do without even knowing: blood pressure control, sugar control, lipid control, lifestyle, smoking, also things we avoid. You avoid certain antibiotics and that sort of things. We do it without even realizing, but it's part of the renal protective strategies. We do have a question here, I think, or do we have a raised hand? I'm not really familiar of how to approach. How do we see whose hand is raised here? Whatever. Participants, yeah. Okay, I think we got a question from two questions, one from Professor Lazarus and one from Dr. Kholi. We can take Dr. Kholi's question first.
Thank you, Cleve. Sorry, man, I just couldn't find the unmute button. Thank you very much, and Happy New Year to everybody. And it's a great talk from Dr. Rhode. I just want to ask one quick question. There's a never-ending battle with radiologists about contrast nephropathy. Why can't, and every time you listen to chronic kidney disease presentations, this is ever rarely mentioned that contrast can give these problems. Can we not get to a point where we actually put this thing to bed and then make it a bit easier for us to get the CT scans that we want? Because oftentimes we are made to jump so many.
Yeah, thank you very much for that question, Doc. I think that's quite again, besides the whole CKD pathophysiology, that's a very important, that's something that we encounter quite often, and it's often a pain because you want the best for the patient, but you also don't want to do any harm, Dr. Rhode.
Thanks, Dr. Kholi. I'm just going to start by saying I think that's a great question, because it's something that you do, of all of the things in CKD as a practitioner, you do think of that when it stands in the way of you and getting an image. I haven't looked at that recently, so I actually really can't give you any evidence-based if it's concrete. But from what I last remember is that there's not really concrete evidence to say either or. And the verdict is still out, and I think that there are proponents that will both say that there's a risk, and there are proponents. I remember at Port Elizabeth's ICU, they were quite big on the fact that that is a bit of a unproven thing. So I don't know what the evidence is since then.
Just thanks, Eli. Just touch on that. I think most of the more recent data is actually swaying away from this contrast-induced nephropathy. I think it's based on the fact that a lot of the papers which were originally published, they use different sorts of contrast agents. Contrast is a lot more safer, renally safe these days. They also, I think the latest sort of data talks about a GFR of about up to 30, which is still probably safe, but that goes within hand of your pre-hydrating your patient, making sure they get adequate fluids afterwards. So it was a lot more of a fear back in the day, I think, but I think people are sort of moving away from or being able to administer contrast with a lot more ease these days. I don't know if that helps you, Dr. Khuli. And then we got a raise hand from Professor Lazarus.
Thank you. Can you hear me, Cleve?
Yes, Prof, loud and clear.
Thank you. Eli, a fantastic talk. You wasted in urology. You should be a nephrologist with all the information you supplied there. It was so clearly presented, so the heavy lifting was demonstrated. Thank you very much. You spoke about something unique in Southern Africa, which I didn't quite catch, related to chronic kidney disease. What was that?
Hi, Prof. Can you hear me?
Yes.
Okay. Prof, so what they're talking about is a gene, apolipoprotein 1, I believe. And there's been interest in the fact that the African population who develop hypertension and hypertensive chronic kidney disease seem to have a genetic predisposition. But once again, it's one of those non-clear-cut genes in terms of you need more than one mutation. It's not 100% proven, but there is some sort of a link. And I think that the work stems from African sleeping sickness, where it was also noted that apolipoprotein 1 made individuals susceptible to the disease in Africa. So they've also looked at that in terms of HIV and your risk, because not everyone with HIV and a low CD4 count, and I mean, we know that, develops HIVAN. So they've also looked at that, and they also feel that there's a link between that. There's nothing concrete. I think it's sort of one of those areas that the verdict is still out there, but something to watch.
Thank you.
All right. If there are no further questions, we're going to